Hello, everyone. My name is Alberto Avila from Mexico City, and I have the pleasure to co-chair this symposium with my colleague and friend, Dr. Romero from Ireland. And many thanks all of you for your interest in the fascinating topic of the frailty of older persons. We have made the effort to bring together a number of international experts to talk about frailty within this international congress of the International Association of Gerontology and Geriatrics. So the world is aging. By 2050, nearly a quarter of people will be 60 years or older in the world, and 80% of them will be living in low and middle income countries. So all countries face major challenges to ensure that their health and social system are prepared, and all areas of healthcare practice will be affected by this rapid demographic shift. Without a doubt, frailty is one of the most controversial terms in medicine and the cornerstone in geriatrics. And in recent decades, much has been written about this phenomenon, so particular of the older adults. However, frailty is not a new concept, since for many years and even centuries, poets, writers, the first scientists, and obviously physicians have observed and describe a state of great vulnerability that make older people not respond correctly to situation of stress or adaptation. Historically, old age, disability, dependency, or living in an institution have been used as synonym for frailty. But it was until 2001 that the Dr. Linda Fried Working Group proposed for the first time a theoretical, practical, and understandable framework for most scientists, which led to the operationalization of the definition of frailty and took more interest worldwide. However, over time, there is still a lack of consensus on how to define frailty, and multiple definitions have been proposed. Essentially, they all refer of a state of high vulnerability and poor resilience that exists in people facing multiple failures in their systems in response to different biological, psychological, and social phenomena. So, frailty refers to a condition or syndrome which results from a multisystemic reduction in reserve capacity to the extent that a number of physiological systems are close to or past the threshold of symptomatic clinical failure. As a consequence, the frail person is at increased risk of disability and death from minor external stressors. Currently, frailty has shown its usefulness in identifying people in a state of risk of adverse health-related outcomes, but it is still also a useful prognostic factor for making difficult decisions, because frailty itself better reflects the overall health status of older person beyond chronological age. In addition to the fact that there is evidence that support the frailty concept as a dynamic state with the potential to reverse. However, not everything is perfect. Many frailty tools have been developed and validated, which could capture different geriatric syndromes. Therefore, no tool is better than the big picture of the comprehensive geriatric assessment, and it could be that different frailty tools may be suitable for different purposes and settings. In addition, it is necessary to emphasize that the concept has gone beyond geriatric medicine, and other disciplines has been able to take advantage of it. And this is the essence of this symposium, the first symposium. Roman, please.
Thank you very much, Alberto. So against this background, who needs education and training in frailty? My name is ROMERO-ORTUNO. I'm Associate Professor in Medical Gerontology and Consultant Physician in Trinity College Dublin, St. James's Hospital in Ireland. And I'm going to drive you through the conceptual need for education and training in frailty. First of all, frailty should be for everybody. Everyone should understand the basics of frailty, not only in healthcare and social care settings, but also at the population level. Frailty, as Alberto eloquently said, is a very hot topic inside geriatrics, but really outside geriatrics is taking a form in very important shape to shape healthcare outside geriatrics. So the proportion of geriatric patients outside geriatrics will continue to increase. In many countries, the number of geriatricians and access to comprehensive geriatric assessment is limited. And in many non-geriatric specialties, the frailty model of baseline, stressor, vulnerability to compensation still applies. So frailty tools can help identify risk and refine therapeutic approaches also outside geriatrics. So what are the words of embracing FROG? Geriatric presentations at geriatrics can be complex, so embracing FROG can therefore enhance patient safety and satisfaction, make professionals' life more rewarding, and also create new specialist care pathways and services, and also expand research and innovation in a relatively new area. So this is what the FROG Symposium is going to bring us today. So we're going to hear from Maria DIEHL, endocrinologist from Argentina, on bone fragility from an endocrinology perspective. Then we'll hear from Nicolò BATTISTI, oncologist based in the UK, regarding geriatric oncology and how moving the needle towards an evidence-based precision approach for older adults based on frailty could help cancer treatments. Then we will hear from Kristine ERLANDSON, infectious diseases based in the US, about incorporating frailty into the evaluation and management of infectious diseases. And then Jonathan AFILALO from McGill University in Montreal, cardiologist, will tell us about a new subspecialty, namely geriatric cardiology. Thank you very much for your attention, and we hope that you enjoy this symposium.
Hello, everybody. I am Maria DIEHL. I am an endocrinologist with Hospital Italiano de Buenos Aires, Argentina, and also coordinator of the National Hip Fracture Network. It is an honor and a pleasure for me to participate in this symposium, and I want to thank the organizers for their kind invitation. Frailty assessment is essential for enhancing patient care. In fact, endocrinologists are likely to be more familiar with the situation in this cartoon than with current geriatric definitions and scales. Frailty, assessed by the Clinical Frailty Scale, was found in 46.3% of the hip fracture patients in our hospital, far more frequently than in community-dwelling elderly adults in Dr. Neverovsky's study, where 8.8% were frail. As it can be expected, mortality rates were higher in frail patients after hip fracture in our institution. We also observed that death occurred closer to the fracture event in this population. The first fracture requires evaluation and treatment in order to prevent subsequent fractures, but this opportunity is frequently lost. More than a third of hip fracture patients had a previous event, like a wrist fracture in this case, but after a fragility fracture at any site, and also post-hip fracture, the treatment gap is between 60 and 70%. A fragility fracture is certainly a well-established major risk factor for further fractures, especially in the first 2 years. Contralateral hip fracture prevalence was 9% after 1 year in a Danish publication, and in a study made in Dublin, 46% of second hip fractures occurred within 3 years. Effective treatments are available, but despite recommendations for post-fragility fracture osteoporosis management, the rate of diagnosis and treatment is still unacceptably low. Therefore, we should optimize secondary prevention in order to change the New York Times fracture forecast. Frailty is associated with poor outcomes, including fractures. The hazard ratio for fragility fractures in this meta-analysis was 1.57 between frail and robust adults. On the other hand, fragility fractures promote both frailty and new fractures. Fracture impact in quality of life of patients and caregivers, healthcare costs, and mortality is well known. So, it's high time we focused on fractures. The most renowned post-fracture care programs are the Fracture Liaison Service and the Orthogeriatrics Service. They have shared interventions for subsequent fracture prevention, and both have proven to be cost-effective. FLS primary goal is secondary fracture prevention, while OCS are focused on overall patient outcomes. Real-time quality indicators are helpful for improving standards of care. The combination of these two models may be a successful strategy. FLS can improve initiation of treatment and reduce refracture and mortality rates. Hip fracture care is provided in our institution by a facility fracture interdisciplinary unit that includes an FLS and an institutional hip fracture audit. Identification is the first step in an FLS. In our institution, after systematically identifying hip fracture patients, our aim is to maximize patient care. A coordinated and interdisciplinary team needs to assess all these issues in a timely and coordinated manner. Geriatricians work together with orthopedic surgeons and other specialists in order to deliver patient-centered care. As an endocrinologist, I am a member of this team. Osteoporosis management post-hip fracture includes correction of vitamin D insufficiency, ensure adequate protein and dietary calcium intake, rehabilitation, treatment of diseases that might be causing bone loss, anti-resortive or osteoanabolic treatment when indicated, and falls prevention strategies. Only 19% of our patients with hip fracture achieved the desirable target above 30 nanograms per mil. 55% had less than 20 nanograms per mil, and 22% had severe deficiency. Calcium dietary intake was appropriate in 15%, and 68% of patients showed secondary hyperparathyroidism. Vitamin D is essential for fracture prevention and also for fracture repair and rehabilitation. Inkster and collaborators found an odds ratio of 2.84 for contralateral hip fracture in vitamin D deficiency. In 2007, Lyles and collaborators published a landmark study on secondary prevention after hip fracture. Treatment with zoledronic acid together with calcium and vitamin D after hip fracture in the next 3 months showed a 35% and 30% reduction in new clinical and new hip fractures respectively. A 28% reduction in relative mortality was also observed in the treated group. We carried out a study on bisphosphonate use after hip fracture, and we observed a reduced risk of mortality in treated patients. Factors associated with increased mortality were age, dementia, and diabetes. The effect of an early and prolonged lockdown during the COVID-19 pandemic had a big impact on hip fracture epidemiology and care in our institution. Patients were more comorbid, less active, and frailer. There were 2 important changes in our usual care. We decided to introduce zoledronic administration during hospital stay which proved to be safe with careful patient selection and provided that adequate calcium and vitamin D were indicated. In fact, one benefit derived from the pandemic was the implementation of telemedicine that improved follow-up. As regards secondary fracture prevention, calcium and vitamin D were more frequently indicated, as well as bisphosphonates, mainly zoledronic acid, during the first months of the COVID pandemic. And time between surgery and zoledronic administration was significantly reduced. Follow-up improved thanks to telemedicine. Regarding frailty outside geriatrics from an endocrinologist point of view, frailty assessment should be taken into account in fracture risk stratification and osteoporosis treatment. Fracture care programs such as OCS and FLS are complementary and effective. Managing frailty as well as bone fragility is essential to bridge the secondary prevention gap and reduce morbidity and mortality after hip fracture. In order to achieve this goal, the Argentinian Hip Fracture Network, RAFCA, comprises 11 associations from different disciplines concerned about fractures and frailty. I'd like to share with you the accomplishment of an Argentinian 82-year-old lady who is a vivid example of how exercise, healthcare, and social bonds can prevent frailty, ensuring better life quality. This is Grandma Elisa with her grandson, Neuen Forti, a colleague of mine. I want to acknowledge Bruno Boyetti, Betiana Perez, and Ivan Huespe for their contributions for this presentation, and also the Fragility Fracture Unit team. I'd especially like to thank the scientific committee and all of you for your kind attention.
My name is Nicolò Battisti. I'm a medical oncologist and I work in the breast unit of the Royal Marsden Hospital of London in the UK. My main clinical and research interests are breast oncology and geriatric oncology. I am the president-elect of SIOG, the International Society of Geriatric Oncology, which is a professional organization grouping clinicians and investigators with multiple backgrounds with an interest in the field of geriatric oncology. Today, I'm hoping to convince you that there are great opportunities in the field of geriatric oncology to maximize and offer our patients a good chances of precision medicine in the management of their cancer. These are my disclosures. Why is it important to discuss and prioritize the management of older patients with cancer? This is because around 50% and 50% of cancer cases and 70% of cancer-related mortality occurred in individuals aged over the age of 65. We also know that based on epidemiological data from the States, by 2040, we are expecting to have 73% of cancer survivors are above the age of 65 in that country. And as you can see in this graph, we will observe, compared with 1975, a 17-fold increase in the cases of cancer in people aged over 85 years, a 10-fold increase in the 75 to 84 years age group, and a 6-fold increase in the 65 to 74 years age group. And really this tells me that it's important to prioritize this population of patients when it comes to educating and upskilling the cancer workforce, but also when it comes to develop national cancer control plans, and also in research and expand the evidence base that is guiding our treatment recommendation for this population of patients. This is critical because for more than 20 years, we've been knowing that evidence in the evidence base in older patients with cancer is perhaps less valid compared with the more general cancer patient population. And this is because typically older patients, they tend to get more frequently excluded from clinical trials in oncology. Laura Hutchins demonstrated this in 1999 on more than 160 Southwestern Oncology Group clinical trials and showed us that at that stage, 25% of the patients recruited in these studies were over the age of 65, whereas at that stage, in the US cancer patient population, 63% of individuals were age over 65. And 15 years later, Harti showed us that we had made very little progress when she looked at NCI-sponsored clinical trials, again in the States, and showed us that at that point, less than 10% of these patients were older, as opposed to 28% in the general US cancer patient population. And again, this tells me that sometimes the evidence that I am using to guide my treatment decision recommendations to patients may be less valid, less applicable in the real world. This also generates significant variation in the management of cancer in older individuals. Here on the left, I'm showing you some data from the Bridging the Age Gap study, which is an observational study that recruited a large number of older patients over the age of 70 with primary breast cancer here in England and Wales across 56 breast units. And as you can see here, this study included also geriatric assessment to really give us some insight on the fitness, the health status of these patients. Even if we know that, for example, when it comes to early stage breast cancer, in the older patient population, only those with high risk disease, so breast cancer at high risk of recurrence, do benefit from chemotherapy. Even when we identified fit patients by means of geriatric assessment within this study, we found that only 27.8% of these patients with high risk disease and healthy were offered chemotherapy. And this was a study looking at the management of breast cancer between 2013 and 2018, so with contemporary treatment regimens. Here on the right, the age is no barrier to chemotherapy analysis was again another UK analysis on cancer registry data on a large number of patients. Here I'm showing only the patients, the data on patients with early stage breast cancer, stage 2 to 3, that underwent surgery between 2013 and 2015. And as you can see in these funnel plots, on the x-axis, we reported what is the caseload of each individual hospital here in the UK, which is represented by each one of these circles. And on the y-axis, the rate of use of systemic anti-cancer treatment adjusted for several factors, including tumor and patient characteristics. It's quite clear when we compare the data for younger patients and patients over the age of 70, that obviously the use of systemic anti-cancer treatment is much lower in the older patient population. But there is also a more significant degree of variation in the use of systemic anti-cancer treatment in the older patient population as opposed to the younger patient population. And when we looked, for example, only a patient with DIEHL negative, so estrogen receptor negative breast cancer, typically a patient that we would have a very low threshold to treat with, to offer chemotherapy, we found that there were far less patients, 33%, receiving chemotherapy in the older age group compared with the younger age group, 92%. And this is obviously because, as our geriatrician colleagues taught us oncologists, older adults are incredibly heterogeneous. And this is true also in the oncology field. As we are born more or less equal, but as we age, we become increasingly diverse under the pressure of several factors, including cancer itself, comorbidities, different health behaviors, different level of access to healthcare, because we live in different places in the world and we have different levels of social support. And I can see in the clinic older patients that are incredibly fit, with a longer life expectancy, with a minimal burden of comorbidities, functional impairment, with a good organ function preserved, where the focus of my treatment recommendations could still be survival. On the other end of the spectrum, patients that are incredibly frail, with a shorter life expectancy, significant burden of comorbidities, polypharmacy, functional impairments, reduced organ function, that are an increased risk of toxicities, where the focus of care should increasingly be quality over quantity of life. And this is a major hurdle for us in the oncology field, because sometimes telling the difference between fit patients or frail patients, or patients that may be apparently fit or apparently frail, is quite a challenge. And as we learned by you, geriatricians, comprehensive geriatric assessment is the answer to this dilemma. There is significant evidence showing that CGA can be applied successfully and benefit also older patients with cancer, and this should lead to expanding the scope of traditional multidisciplinary team in oncology that obviously include medical oncologists like me, radiation oncologists, surgeons, nurses, but should also include, where available, geriatricians, multidisciplinary teams including allied care professions like dietitians, pharmacists, physiotherapists, occupational therapists, social workers, psychology teams, supportive care teams, and with close involvement of primary care and caregivers to really provide these patients with holistic and personalized care. And for those of my colleagues that feel that geriatric assessments are time-consuming, there are several geriatric screening tools that have been validated in the oncology settings. And as you can see in this table, these include tools like G8, VES13, SOP2 or SOP3. And these tools have different obviously levels of sensitivity and specificity to predict outcomes of the comprehensive geriatric assessment. And these tools are endorsed by also international consensus, but we should always bear in mind that they should not replace a full geriatric assessment for patients that screen positive on these tools. And whereas I can manage like younger patients, those that screen negative, I will still need to go ahead with a CGA for those patients that flagged for vulnerabilities on these tools. But what are the benefits of integrated oncogeriatric care in this setting? Historically, several pieces of evidence has shown that actually I can, as an oncologist, I can be much more accurate in estimating survival for older patients with cancer, predicting treatment complications or physical decline on the number of anti-cancer treatment options. I can improve the mental health, the well-being of my patients. I can support my treatment recommendations, and I can find problems that are neglected by a number of routine assessments that are obviously mainstream in the oncology field. But crucially, over the last couple of years, 3 randomized clinical trials have also showed benefits on other endpoints that traditionally the oncology community feels like much more attractive. And these endpoints are the risk of side effects, severe side effects on systemic anti-cancer treatment, the risk of unplanned hospital admissions, again on systemic treatments, quality of life, and the reduction in intensive care unit admissions and hospital and the length of stay after surgery for surgical patients. And this is the reason why now, obviously, a number of international guidelines and consensus, like, for example, ASCO and CCN and SIOG, do recommend the integration of geriatric assessment into routine care of older patients with cancer. A very quick and easy application of this in the oncology field is, for example, the possibility to predict the risk of severe chemotherapy toxicity in this population. And again, this is something that many oncologists find quite attractive, because obviously this can significantly enrich the discussion that we have with our patients. As you can see here, we have, for example, 2 tools, the CRUSH score and the CARG score. And as you can see in this slide, they include a consideration of lab values, LDH, hemoglobin levels, creatinine clearance, clinical parameters like blood pressure, characteristics of the cancer or the chemotherapy that I am considering for this patient, those reductions up front or mono versus polychemotherapy, and geriatric domains, such as, for example, cognitive status, nutritional status, the number of falls over the last 6 months, IADLs, social support. And I can combine this in these models and actually derive from these 2 tools a score that would tell me what are the chances of that individual patient experiencing severe side effects, so side effects on chemotherapy requiring hospital admissions. And as you can see here on the right, The CARG score, for example, has been compared with a much more frequently used tool in the oncology setting, Karnofsky performance status, and has been shown to outperform Karnofsky performance status when predicting the risk of severe toxicity in this population. And this is what I think about when I say that there are a number of assessment that we use and consideration that we use in the oncology field that actually could lead to issues and neglect problems that we would typically find on geriatric assessment in these patients. Geriatric assessment also offered the unique opportunity to expand the evidence base for the management of older patients with cancer, or what we say geriatricizing clinical trials. As I mentioned, older patients they tend to be excluded more frequently from clinical trials, and if I use geriatric assessment, I can perhaps better allocate patients to individual arms within clinical trials. I can use them to predict the toxicities on whatever experimental treatment. I can also select endpoints that are sometimes more relevant for older individuals: quality of life, treatment tolerability, physical function impact. And I can expand, relax the eligibility criteria to make sure that I am enrolling into these trials much more real-world population of patients that are not just older, but also more reflective of what are the characteristics of the population of patients that I'm seeing routinely in the clinic. And this is to give you an idea of a few trials that I mentioned in my talk. These are the two trials that recently have documented a reduction in the risk of severe systemic anti-cancer treatment toxicity in this population of patients when they are managed with an oncogeriatric approach. GAP 70 on the left recruited more than 700 patients over the age of 70 with incurable stage 3 or 4 cancer, initiating a new line of systemic anti-cancer treatment. And in this study, patients were randomized to standard care versus a geriatric assessment-driven set of interventions recommended by geriatric oncology team, working alongside more than 40 community oncology practices in the States. And as you can see here, patients randomized to a geriatric assessment-driven intervention, they had lower rates of toxicity. Hematological, non-hematological, and overall toxicities. That's perhaps explained by the fact that oncologists seeing patients randomized to the geriatric assessment intervention arm were more wary of using upfront dose reduction more frequently. But this did not document any impact on survival outcomes in this study. The GAIN study on the right had a very similar design, although it was a study involving only one single center in California. This study enrolled 600 patients over the age of 65 with solid tumors of any stage, also curable tumors, initiating a new line of chemotherapy. And as you can see here, patients were randomized again to standard care versus oncogeriatric care under the input of a multidisciplinary geriatric oncology team. And as you can see here again, this study did document similar benefits: a reduction in the risk of overall toxicity, hematological toxicity, non-hematological toxicity, and crucially, also a benefit in the completion of advanced directives in this population. As obviously, oncology is much better in discussing these aspects with the patients. This is the study Integrate that looked at impact of oncogeriatric care on quality of life, which is, as I say, the critical endpoint in this patient population. The study recruited 154 patients over the age of 70 with solid tumors and aggressive lymphomas, starting a new line of systemic treatment in 3 general hospitals in Melbourne, Australia. And perhaps not surprisingly, as you can see here, these patients randomized to an oncogeriatric approach had consistently better quality of life outcomes over a period of 24 weeks, as opposed to those randomized to standard care. And this study, an oncogeriatric approach, involved essentially the input of a geriatrician throughout the treatment pathway of these patients. And the Integrate study as you can see on the left, also showed a reduction in the emergency presentation, unplanned hospital admission and overnight bed days, and lower early treatment discontinuation due to toxicity in, again, patients randomized to an integrated oncogeriatric approach. And this might also suggest that these models of care will hopefully become increasingly sustainable in the oncology setting. On the right, this study, the KIAN study, was presented again at ASCO 2020, the American Society of Clinical Oncology meeting. And this was the surgical study that actually looked at impacts of oncogeriatric care in patients with upper and lower GI malignancies being considered for surgery and age over 65. This study was conducted at Boston, Massachusetts General Hospital in the US. And although the study itself was negative, when we looked at the per protocol analysis, so for patients actually did receiving integrated oncogeriatric care, these patients had shorter postoperative hospital stay and lower rates of intensive care unit use after the surgery. In conclusion, this is to me really what I call precision medicine. And this is because in the oncology field, we have been stuck for a very, very long time with informing anti-cancer treatment decisions solely or mostly based on histology, grade, stage, and a number of biomarkers that now have become available and are routinely used in clinical practice. Whereas we have always focused very much on traditional or historical patient-related measures such as performance status or consideration about chronological age. But we are now hopefully increasingly becoming aware of the impact of geriatric assessment and during interventions on the management of these patients. And we should really have the same shift that we have over the last 20 years when we started implementing a number of biomarkers to drive our treatment recommendations and really start to implement geriatric assessments in the context of individual life expectancy, organ function, comorbidities burden, functional reserve, social support, quality of life considerations when actually issuing our treatment recommendations and discussing pros and cons of anti-cancer treatment options with our patients. And again, integrating this with tumor-specific considerations. I just thought I could conclude with highlighting a few resources if you want to learn more about the geriatric oncology field. Obviously, our society SIOG website, the Cancer and Aging Research Group website, the Moffitt Cancer Center website includes also a number of tools that you can use in your practice for managing older patients with cancer. There is the Association of Community Cancer Centers in the US that is doing a lot in the field as well. On the website, you can find a lot on the field of geriatric oncology as well. And we have our publication, our official SIOG journal, which is Journal of Geriatric Oncology, where you can find all the research from basic translation and clinical research in the field of geriatric oncology, and a very active social media community, as you can see here. And let me also invite you to our annual conference that will take place in Geneva on the 28th to 30th of October 2022, and invite you to submit your research. The deadline is 8th of May. And I would like to thank you all for your attention, and I'm very happy to take your questions.
Thank you for the opportunity to present in this symposium and to the initial speakers for laying the groundwork for such an important discussion. I'd like to start by sharing some of our experiences and how we've incorporated frailty into the field of infectious diseases. To begin, when we conceptualize frailty as a vulnerability, it isn't surprising that frail individuals may be much more likely to develop infections or to experience poor outcomes following an infection. Urinary tract infections, or UTIs, are an excellent example as outlined in this conceptual figure. Frailty can be associated with malnutrition, sarcopenia, and cognitive impairment. Frailty is also closely linked to declines in immune function, in addition to the declines in immune function that we see with increasing age. The combination of all of these factors contributes to a greater likelihood of urinary tract infections. The increased risk of other infections, such as pneumonia, and subsequent poor outcomes following pneumonia likely follow a similar conceptual pathway. Over the last few years, we have also seen that in times of critical healthcare shortages and an epidemic, frailty can help to guide treatment decisions of infectious diseases. Early on in the COVID pandemic, some healthcare systems utilized the clinical frail scale to ensure that those that were least likely to survive COVID had their wishes and desires for the aggressiveness of their care addressed. Indeed, over the subsequent 2 years of the epidemic, or the pandemic, we've seen that frailty better predicts COVID outcomes than age alone, that frail patients may have more atypical COVID presentations, and that frailty may impact vaccine efficacy, among other findings. But how do we think about frailty in the setting of a chronic infection that persists for many years, such as that of HIV? We are now more than 40 years into the HIV epidemic. More than half of people living with HIV in the United States are now over age 50, with a similar increase in proportion of people aging with HIV globally. Although relatively few people with HIV are currently over age 65, many of those older adults have been living with HIV for more than 20 or 30 years and are developing numerous comorbidities and even geriatric syndromes 10 to 20 years prior than their peers aging without HIV. Numerous factors are thought to contribute to this early development of comorbidities, physical and cognitive impairment, and ultimately a decrease in health span and quality of life. Certainly HIV itself is a major contributor, even in those that are on suppressive antiretroviral therapy. And we can continue to see low levels of inflammation in that population. People with HIV also experience many structural inequities and biobehavioral factors, often to a greater degree than among people aging without HIV. Although many investigators recognize the frail-like appearance of AIDS patients early on in the epidemic, the first description linking HIV to frailty was published in 1992 by 2 investigators at Johns Hopkins University, a site of both a longitudinal study of men with HIV, and also a site where investigators Linda Fried and Jeremy Walston later crafted the frailty phenotype. Much of the initial research with frailty in HIV thus has been focused on using the frailty phenotype and was really focused on that overlap between immune dysfunction and frailty, as we were just beginning to understand the similar immune underpinnings of frailty. Over the past 10 years, the links between frailty, regardless of the definition used, and HIV have become even more apparent. Many of the same pillars that underlie the development of frailty in the general population are also impacted by HIV. With chronic HIV infection, we see increased levels of inflammation, DNA damage and epigenetic alterations, changes in metabolism and hormone regulation, among other pathways. The additional impact of HIV on each of these pathways contributes to the greater prevalence of frailty and physical function impairments that we do see in people with HIV. Our group and many others have shown the relationship of many of these different pathways to frailty in people with HIV, as indicated by just a sample of recent publications. In fact, many have proposed that HIV may be associated with an accelerated aging process, which may actually be most clearly manifest by the phenotype of frailty. Indeed, we see a greater proportion of frailty with increasing age among people with HIV, as you can see on the figure on the left, focusing on these darker gray bars that increase with increasing age, indicating frailty among those with HIV shown in the columns on the left. In the figures on the right, we also see faster declines in objective markers of physical function, such as gait speed and grip strength, among people with HIV, shown in the red line, compared to those living without HIV in the blue line. Why should we care about these measures? Well, both frailty and functional impairment are strongly associated with mortality, and we even see that this is true in younger populations of people with HIV and frailty. This is data in the figure from a cohort of people using injection drugs with and without frailty and with and without HIV. You can see a synergistic effect of both HIV and frailty on mortality risk, with the lowest survival in the yellow line, where people have both HIV and frailty, and the highest survival in the top blue line, where people have neither HIV nor frailty. We see similar effects when looking at the short physical performance battery or other measures of frailty and function. We've shown that frailty and physical function impairments are associated with falls and fractures, as well as an increased risk of many comorbidities, including cognitive impairment, diabetes, and cardiovascular disease. We have begun to incorporate frailty and physical function into both clinical trials and observational studies in a few different ways. First, we can study the epidemiology and risk factors for frailty. Here in the HIV research realm, many of the earlier cohorts incorporated the frailty phenotype, and this is probably still the most referenced description of frailty in HIV. More recent studies have also incorporated the short physical performance battery or modified versions of this, as well as the frailty index. The Veterans Hospital Administration developed a frailty index type score that includes only routinely collected laboratory values. This is shown to be strongly predictive of mortality in both people with and without HIV, but may or may not overlap well with the actual frailty phenotype. Second, we can test interventions that we believe will reverse frailty or change the trajectory of frailty. However, because frailty is still relatively uncommon in many of our clinics, with a prevalence of approximately 5 to 10% of individuals being frail, this can be harder to intervene upon as well. So objective measures of physical function may be more useful, may be easier to identify in patients, and may allow studies to intervene at an earlier state to prevent progression to frailty. For example, we're conducting exercise studies in many of our middle-aged or older individuals with HIV, and we used outcomes such as the 400-meter walk or the short physical performance battery in many of our studies. Lastly, we hope to use frailty and physical function more to understand who does or does not respond to different interventions. For example, we're including the short physical performance battery and frailty in a trial of statin therapy in younger individuals with HIV, and to understand whether frail individuals experience more side effects or more benefits in the setting of a randomized clinical trial. Incorporating frailty into the clinical setting in HIV is relatively new, and we know little about how we can actually incorporate these types of assessments into the clinic flow. In many countries, the HIV physician is the primary care physician. Visits, therefore, are often focused on addressing many primary care issues in addition to HIV care, and there's often little time left for other assessments, such as a frailty assessment. Other clinics have begun embedding a geriatrician into the HIV clinic or establishing referrals for geriatric care for some patients. For these clinics, frailty has been proposed as a way to possibly identify higher risk patients that may be appropriate for a referral to a geriatrician. Or patients might be referred for other reasons and then have a more detailed frailty assessment as part of a comprehensive geriatric assessment. The VAX index, or the clinical frail scale, might work best in these types of settings where we need to identify at-risk patients with a brief assessment, and then things like the frailty phenotype or the short physical performance battery has been used in settings where we have more time for a longer assessment within the comprehensive geriatric assessment. A few HIV geriatric clinics have started to use frailty to inform care and needs for older adults, to act upon different components of the frailty phenotype, but data on outcomes and success of reversing frailty is fairly limited at this stage. Very few of our HIV guidelines have incorporated routine recommendations on frailty or physical function screening. However, it's certainly a growing interest to understand geriatric care and how we can work frailty assessments into the clinical setting. And lastly, I want to emphasize how important it is to gather the input of the community and the patients who are undergoing these types of assessments. We attempted to establish a referral program for older adults with HIV in our clinic, many of whom were referred by their providers, and very few patients actually wanted to see a geriatrician because they didn't identify themselves as old. Similarly, if patients have competing priorities, an assessment of frailty that takes up 10 minutes of their precious visit time may be seen as more of a nuisance. The advocacy of the HIV community has really been a driver of developing treatments and is now pushing us to improve the care of older adults with HIV. The input of the community is really crucial moving forward. And we've seen a lot of our advocates, such as this pictured here, have really been instrumental in moving this field forward. To summarize, frailty is associated with increased risk of many infectious diseases and a risk for poor outcomes following infection. Some chronic infections may have features that overlap with frailty, and frailty can occur earlier among people with these infections. Simple assessments of frailty may also help guide referrals or inform care for people experiencing accelerated aging who might not otherwise fall under the care of a geriatrician. I thank you for your time and look forward to the question and answer discussion. Thank you.
Hi, my name is Dr. Jonathan AFILALO. It's a pleasure to be with you today to discuss a new subspecialty, geriatric cardiology. Cardiovascular disease has evolved for a large part to become a multi-system disease complex. And in particular with heart failure, the number of non-cardiac conditions often outnumbers the cardiac conditions in any given patient. And so it's important to have a holistic view of the patient in their assessment and also their treatment. This is where geriatric cardiology comes in. And one thing that is been popularized in terms of representing the patient in a holistic way, representing their impairments beyond their cardiac condition, is frailty. And frailty can be viewed as the sum of the impairments related to aging in any given individual, and particularly those impairments that are associated with adverse health outcomes. When we add a stressor to the mix, we appreciate the patient's resilience to bounce back from that stressor, again, as a function of their frailty. When we consider the environment, well then the sum of frailty and the environment is often a good proxy of the ensuing disability that the patient may manifest. And whether we view the impairments as a narrow cluster of items relating to muscle mass, function, or whether we view them as a more broad cluster, not just limited to muscle mass, the concept remains the same. So on the far left, we have the so-called sarcopenia phenotype and the models such as Fried's, where we view mainly the physical impairments related to muscle loss with age. On the far right, we see the deficit accumulation type models where we view much more than just muscle related impairments. We may view mental, cognitive, symptoms, diseases, lab abnormalities. And then in the middle, we have a middle ground, which was the intrinsic capacity scale proposed by the WHO, where we'll consider a moderate number of impairments as relating to frailty. But again, the concept is what's important, not necessarily the specific scale. Within these different scales, we may find a number of impairments, and I'll go through a few of them as we've studied them in cardiovascular patients. So one impairment is slowness as measured by gait speed. So we studied this in cardiac surgery and showed that as patients walked more slowly, they had a higher likelihood of death or morbidity after surgery. Another is weakness as measured by grip strength. And we've studied how patients with weaker grip strength have higher risk of both short-term and mid-term mortality after surgery. They also have longer length of stay. They also have higher rates of discharge to healthcare facilities, so they're less likely to go home. Another is inactivity or sedentariness as measured by structured physical questionnaires. And here we found that the kilocalories per week, when they were quite low, and in general, they were quite low in patients of advanced age undergoing aortic valve procedures. When this was elicited, patients had a significantly increased risk of mortality 1 year after the transcatheter aortic valve procedure. The combination of physical frailty and malnutrition is a bad one. And in this case, we found not only that malnutrition as measured by a brief questionnaire was predictive of mortality after an aortic valve replacement procedure, but that the combination of malnutrition and a physical frailty as measured by the short physical performance battery was exponentially bad from a prognostic point of view, with these patients having a 41% mortality rate after an apparently successful aortic valve replacement procedure. Looking at some of the non-physical domains, of course, depression as measured by a brief questionnaire has shown to be predictive of mortality after these procedures, almost a doubling of the risk of mortality after accounting for potential confounders. We've shown that anxiety is equally, if not more, predictive of mortality or major morbidity after cardiac surgery. And this is something that perhaps we don't talk about as much, but that can be measured using structured questionnaires. And finally, disability is often the end result where a lot of these impairments will funnel down into. And disability is defined as being dependent or unable to perform either basic or instrumental activities of daily living. And this is important to consider when we're evaluating patients before an invasive cardiac procedure, because this will have a major impact on their ability to recover from said procedure. So this is something, again, that we should be assessing and considering when evaluating an older adult in this context. How could we conclude without discussing cognitive impairment? Cognitive impairment, if we rely on the medical chart to provide us with this diagnosis, we will miss a lot of cases, especially the earlier cases. And so I think it's without question that we should be assessing this, if not with broader tools such as the Mini-Mental or MoCA, at least with screening tools such as the clock draw or the Mini-Cog. And we've really begun doing this on a regular basis in our program. In the frailty AVR study, we asked a question about not only cognitive and physical frailty, but other domains of frailty and how we can best put these together to allow the cardiovascular clinician, whether it's a cardiologist or cardiac surgeon or even a trainee, to quickly and practically assess the key domains of frailty. And what came of that after prospectively enrolling over 1,000 patients across 3 countries was the following scale, which we've called the Essential Frailty Toolset, or EFT. This contains a measure of physical frailty, so the 5 chair rises, contains a measure of cognitive impairment, either through the Mini-Mental or subsequently through the Mini-Cog test. And then it contains 2 readily available biomarkers, so hemoglobin and albumin, reflecting chronic inflammation and also nutritional status. When we combine all this together, we have a score from 0 to 5. It can be done in about 2 minutes at the patient's bedside. And as the patient's score increases, we observe higher rates of death and higher rates of progressive disability. And if we look all the way at the far right, if the patient has 5 out of 5 points on this scale, well, then they have an 80% chance of being in a poor state 1 year after a procedure, even if that procedure most of the time is technically highly successful. So the patient gets a new heart valve, but just does not evolve well thereafter. And I think the frailty is in large part to blame for that. So how do we apply frailty in the clinical care of patients? So here's an example where we had 3 patients, all 3 with severe aortic stenosis, symptomatic. And our first step was calculating their Society of Thoracic Surgeons predicted risk of mortality. So we plug in their age, their comorbidities, their cardiac condition, and somewhat unsatisfyingly, we have a predicted risk that's quite similar for all 3, 6 to 7% risk of operative mortality. How can we get a little bit more granular and really tease apart the differences in these 3 patients? Well, when we did the EFT scale, we found that the gentleman on the left had a very reasonable and modest risk of bad outcomes at 1 year, but that the gentleman in the middle had an over 50% likelihood of 1 year mortality, irregardless of how well the valve could be implanted. Taking it a step further, let's look at the body composition of these 3 patients. And so we took their pre-procedural CT scan, which was done to assess their candidacy for a transcatheter aortic valve. We put it into our software that we've developed called Core Slicer, and that's available online at coreslicer.com. It's an open source software. And we measured their muscle mass, specifically their psoas muscle mass. What's of particular interest is that the 2 gentlemen on the left and in the middle had very similar body mass index, so similar height and weight. But the gentleman on the far left has a much greater muscle mass than that in the middle. And so lifting the hood of the car, so to speak, really shows you a lot about the engine and the composition there. We couldn't really have guessed that just eyeballing these two patients. Furthermore, the patient on the far right looked robust and actually measured out to be on the obese side, but his muscle mass was quite low on the inside. And so this is an example of a phenotype called sarcopenic obesity, which is difficult to guess just by eyeballing the patient, but is quite prognostically bad when we've looked at it in clinical studies. We've done some work to automate this process, including some deep learning models to take an image from a clinical CT scan and output all of these metrics for the clinician to then use them in their decision-making and prognostic estimates. This works quite well. And we've also tried to implement this in the acute cardiovascular intensive care unit setting, where often we're called to help assist in making difficult decisions about invasive versus conservative care in older adults, but where our usual questionnaires and physical tests just cannot be performed because of the patient's acuity. So a good forum to apply some of these frailty biomarkers in this setting. It's important to note that frailty is a state, often a pre-disability state, where the patient is at risk and vulnerable, but it's not necessarily equivalent to futility. And futility is really a more advanced state where no matter what we do to the patient, either by fixing their cardiac condition or addressing their geriatric impairments, there's a likely chance that we won't really make a meaningful impact in their quality or quantity of life. And we developed this ABCDE mnemonic with the Canadian Cardiovascular Society for their guidelines on TAVI. You see here the A stands for advanced dementia, the B for bedbound or non-mobile state, the C cachexia or severe sarcopenia, the D disability for all or most basic activities of daily living, and the E end-stage disease of the kidney, liver, lung, or neoplastic process. As we've matured and evolved in our ability to measure frailty in an objective and increasingly practical way, we're turning our attention to treating frailty, and not just using it as a prognostic risk factor, but also now as a treatment target, where while we're treating the patient's cardiac condition, either perhaps before, after, or simultaneously, we're also taking aim at their frailty. And we're calling on our colleagues in exercise therapy and physiotherapy to provide exercise training to these patients. We're calling on our nutritional colleagues and providing oral nutritional supplementation when needed to, again, improve these patients' nutritional status and physical strength. And of course, we're working closely with our geriatrics colleagues to implement comprehensive geriatric assessments and intervention plans in complex patients. And I think this is really the key to ensuring good outcomes for these frail patients. An example of this is the Target EFT trial led by two of my graduate students, Rosie Funtodos and Fayeza Ahmad. And while patients are admitted to cardiology, getting their cardiac care, what they've done is assess frailty on the ward and then visit patients twice per day to provide them with some bedside exercises, some cognitive stimulation, some nutritional advice and oral nutritional supplementation when needed, and also to remind the team to correct their anemia with intravenous iron if they were found to be deficient. And this kind of combination of interventions targeted to the deficits found was found to be helpful in improving the patient's frailty and their recovery from their cardiac condition. So in conclusion, geriatric cardiology as a subspecialty has a place in contemporary practice. I think we've seen, and hopefully I've shown you, that older adults with cardiac conditions often have intertwined geriatric conditions, which in many cases will be the driver of their symptoms, their quality of life, their prognosis, and their therapeutic treatment. Unfortunately, these conditions, for lack of perhaps time and expertise, have historically been a blind spot for many clinicians outside of geriatrics, but we're working on that. We're developing practical tools and educating clinicians. And I think there's an understanding, a natural understanding, that these are very important concepts that should be applied in clinical care. So for us, we really view geriatric cardiology as not only a core curriculum, but also a potential subspecialization. in which we will strive to assess, interpret, and address relevant geriatric impairments. And we'll do this in an integrated fashion in parallel with our cardiac care, and of course, using a patient-centered shared decision-making approach. Thank you very much for your attention. Here are some tools that are free to use and may help with the assessment of frailty. And of course, our Geriatric Cardiology Fellowship Program. I encourage anyone interested to apply or who has trainees that may be interested to apply to consider this fellowship program. We're open to residents in geriatrics, cardiology, and we provide a one-year curriculum to really go deep into the assessment and treatment of geriatric impairments in our cardiac patients. So again, thank you for your attention and have a great day.
Thank you very much. Hello, everyone. Thank you very much for joining us to the Frog Symposium. And thank you, Maria, Kristine, Nicolò, Jonathan, and obviously Roman for this great discussion about how the geriatric skills must be useful for other specialties. So we have the time for a few questions. Roman, please.
Thank you very much, Alberto. And it's been a massive pleasure to co-host this Frog Symposium with you and with all our friends who spoke about today. I think we've had a very rich set of explanations about different specialties where frailty is becoming a new paradigm. So there's been questions regarding how we approach frailty within non-geriatric settings. So I would like to go around the table and ask our invited speakers, what do you think, how would we approach frailty for the first time if we had never heard about it? And what would give you more confidence to approach it? So Maria.
Well, we need to work together with geriatricians who are really very used to assessing frailty, and we are learning from them and work in an interdisciplinary manner. We know that after a fragility fracture, treatment gap is greater in our institution in frail patients who are at higher risk of poor outcomes. So we really have to work together in order to close the treatment gap in this population.
Thank you very much. Kristine, what's your best tip for getting involved with frailty?
I think it's talking to people who are already incorporating frailty into their clinics or into their research to see how they do it. I'd like to do the combined fellowship that the last speaker spoke about too. That sounds fantastic. Unfortunately, I don't know that it's available in every field, but I think for those that have the time, that's really a really neat opportunity to learn more about incorporating geriatrics into any subspecialty.
Thank you. Nicolò, what's your best tip for geriatrizing the field of oncology?
Thank you very much, Roman. I think from my perspective is start using some tools that are not terribly complicated to use. If you think about the geriatric oncology field, there are several screening tools, geriatric screening tools that you can easily implement in your clinic. They take only a few minutes to run. They can really enrich the discussion that you have with patients. In the oncology field, it's really about a patient level. Reduce the risk of adverse outcomes from anti-cancer treatment in the older patient population, but also incredibly, helping, supporting shared decision-making. So my really top suggestion is start using G8, VES13, SOP3, whatever screening tool you think would work in your own clinic. And then obviously, as the other speaker said, talk with your colleagues, geriatrician colleagues who are available, but also a number of other multidisciplinary professions, physiotherapists, occupational therapists, nurses, get them involved in your clinic. Thank you.
Thank you. And Jonathan, in answer also to a question, how has frailty helped your practice in cardiology? And say clinical parallel.
Sure. Well, it's helped in better assessing the older adult. Our average age is north of 80. And instead of stratifying patients as a function of their chronological age, we're able to reach patients who may be quite advanced in age, even into their 90s, and treat them with the appropriate therapies, not necessarily stopping at chronological age. And the surgeons and proceduralists are particularly receptive and actually seeking this information because they want to make good decisions for patients and have the best possible outcomes. And so that's been kind of one of the main ways we've seen it put into use. And now I think the pearl is not to look at frailty as equal to futility. That's a common mishap. Frailty is not futility. Frailty is modifiable. And, you know, basic things like emphasizing exercise, physical therapy, nutrition could go a long way in frailty. And, you know, we assume it's a given, but oftentimes it's not emphasized to patients. And just hearing it from a clinician that it's important to move around during a hospitalization, that it's important to be active, it can go a long way and make an impact on patients.
Thank you, Jonathan. There's another question as well oriented to cardiac surgery and rehabilitation. So can frailty be a focus for assessing and offering rehabilitation to these cardiac patients?
Yeah, absolutely. Just along those lines, if you identify a patient who needs cardiac surgery, but they seem to be frail, a great idea is to either refer them for prehabilitation or to kind of proactively plan for their referral to cardiac rehabilitation sooner than later after their cardiac surgery. And even sometimes we do it in the hospital. You know, one of the things I do routinely when I have a frail patient who's awaiting surgery in the hospital is not to rush to the surgery, but rather to take a week or so, work with my physiotherapy and nutritionist colleagues to really be present with that patient every day, have the patient self do some measures as well to strengthen and just kind of optimize them from that point of view, from their frailty point of view before they go into the operating room.
Absolutely. Also, Nicolò, I might come back to you as well regarding some rehabilitation for cancer treatments. How do you think frailty tools could help us with this?
And I think they can identify patients where there is much more to gain from prehab. And again, this might be a challenge, for example, when you think about patients suitable for palliative treatment, because they would need more rapidly initiation of systemic anti-cancer treatment because they're symptomatic and so on. But I think, for example, the curative setting is incredibly good setting also to with a bit more scope for prehabbing patients, also for systemic anti-cancer treatment. Historically, in the oncology field, this is something that has been looked at with a bit more detail in the surgical pathways. But I think that we should increasingly do this also in the systemic anti-cancer treatment pathway, because the treatment that we give as medical oncologists are incredibly and increasingly complicated and potentially toxic. So I think rehabbing is really important also when you consider this patient for chemo.
And that applies to surgery and infectious diseases as well, as we know. They tell me we are coming to time, so I'm just going to hand it back to Alberto for a closure. Thank you all.
Yes, I think that a very important question to end this symposium is to know from you a clinical peer about how frailty has helped your practice. Maybe you have a very quickly answered. For example, Jonathan, how a clinical peer, how frailty has helped you practice.
Is that for me?
Yes.
Okay, sorry. It's helped my clinical practice just feeling much more comfortable addressing patients at the extremes of age. You know, for some, seeing a 90-year-old with an acute cardiac issue may be anxiety provoking, because you're not only limited by you're not only having to think about the cardiac treatment, what should I do to fix this patient's heart, but you have a whole bunch of other factors that are swirled in there and complexify, and that could be is often a challenging case. But you know, if you apply some basic principles and start to think about objective concepts of frailty and geriatric domains, you start to kind of simplify or demystify that and see that it's not really that complicated to work through and to take the best decision for the patient. So for me, that makes the process of caring for that patient more enjoyable and rewarding than challenging and mystifying.
Maria, from you, one clinical peer from you to the endocrinologist.
It's not only age that matters, but we can prevent frailty by exercise, good nutrition, and we need to have an interdisciplinary team to address fragility fractures and improve our usual care. Frailty we need to assess it in order to have a better perspective of the patient's risks in the future.
Kristine, please, clinical brief from you.
Yeah, I use it probably most in the patients I see with HIV, and we have younger, older patients, so in their 50s and 60s. And I think frailty really helps us to capture those differences between a 50-year-old who looks more like a 30-year-old and a 50-year-old who looks more like an 80-year-old. And through that, we can then target care towards that patient and what fits their needs and desires, and helps to preserve their function with aging, and helps to minimize harm.
Thank you, Kristine. Nicolò, please.
Yes, I would very much like to echo what Jonathan said. I think frailty assessment makes me more confident in, for example, pursuing or not pursuing specific anti-cancer treatment options for our older patients, because sometimes the benefits of anti-cancer treatment may be quite small. Then, if I see a patient that was frail, knowing that, I will feel more confident and say, this is not a good idea. Or on the other hand, if I see a patient who is incredibly fit, I may actually say, yes, this is a very good idea because I think you could benefit, you would live long enough to benefit from this anti-cancer treatment. So again, it's all about not just being more precise, but also getting more information that would, again, allow me to be more confident in my treatment recommendations.
Thank you very much, all of you. Thank you for joining us to this symposium. Thank you for share your experience, and thank you for your interest in geriatrics skills. And I hope to see you in person, maybe in Amsterdam the next time. And thank you, Roman, for this great idea. And thank you all of you for following us. And we invite you to continue in this international, in this World Congress from the International Association of Gerontology and Geriatrics 2022. Thank you.
Thank you.